everybody, and welcome again to our cardiology grand rounds at the University of Washington. It is my pleasure to introduce among our most favorite recurring visiting speakers, Desiree Marshall, who is faculty in the Department of Lab Medicine and Pathology here at the University of Washington, and the director for autopsy and after-death services at the University of Washington Medical Center, and our guide through clinico-pathologic correlation as usual. So Desiree, thanks very much for being with us. And she's joined with Dr. Fitz Medhane, who's our Chief Cardiology Fellow and helping to lead the conference today. So Fitz, take it away. Desiree, thanks for being here.
Thank you.
Thank you. Let me just make sure. Thank you so much, Dr. Roth, for the introduction. Good morning, everyone. Happy Friday and happy October 1st. Welcome to our weekly grand rounds and our first cardiology pathology conference for this academic year. For those who don't know me, my name is Fitz Medhane and I'm one of the third-year fellows. I'll go ahead with our case today. We don't have any disclosures. Our agenda today, we will be discussing two cases. The general format would be in such a way that we'll have a brief case presentation followed by pathology and or autopsy discussion and case discussion summary for each. I'll go ahead and present the first case. Our first case is a 40-year-old female presenting with PEA arrest. Reportedly, she was with her partner at the time and she was kissing her boyfriend when she collapsed, and it was a witnessed loss of consciousness and she became unresponsive. 911 was called, EMS came in, PA arrest was confirmed, and she had 3 rounds of CPR, 1 round of AP, and ROSC was achieved on the field, and she was headed to Harborview Medical Center emergency room. Part of her past medical history was interesting. She has had recurrent syncopal episodes. She saw a cardiologist in an outside hospital. She explained that she has this exercise-induced syncope, pre-syncope. She had about 15 episodes in the last 5 years preceding to her presentation. And in fact, this had made her decrease her activity due to fear of inducing her symptoms. She also had associated chest tightness, shortness of breath, palpitations, and urinary incontinence whenever she had these episodes. She has had reportedly neuro workup with brain MRI, which was negative, and she also had a cardiac workup with stress test and rhythm monitoring, reportedly negative, although it's very unclear that what type of stress test that she had. And the plan on her most recent cardiology office visit prior to her presentation was to repeat the stress test just because of her recurring symptoms. Otherwise, she doesn't have any surgical history, no medications that she takes, no allergies. On physical exam, her temperature was 33.3, but this was due to targeted temperature management started in the emergency room. Her heart rate was ranging between 46 and 108, blood pressure sort of in the normal range, slightly hypotensive initially, and she was intubated on the field. Her labs include mild hypokalemia with ANA and GAP metabolic acidosis, mild leukocytosis, mild transaminase elevation, and you can see here her troponin in the y-axis, mean nanogram per ml, and time on the x-axis, it shows peak at presentation of 0.07. I know it's a little bit small to see, but it's 0.07. This was her presenting EKG in the emergency room. Apologies for the poor baseline, but it shows sinus tachycardia, poor RF progression, some ST depression in V5-6 and inferior leads, and diffuse T-wave abnormalities that you can see, you can pick out, but otherwise normal QTC. She also had CT angio of the chest to rule out PE, and PE was ruled out based on this study, but it actually found a congenital cardiac anomaly consisting of a presence of an intra-atrial membrane extending obliquely through the left atrium and inserting on the intra-atrial membrane, into which the pulmonary veins drain right here, as you can see. The distal left atrial chamber communicates with the left atrial appendage, and mitral valve findings, as you can see here. And these findings were consistent with core triatriatum, and further evaluation was recommended by echocardiogram. She then later had an echocardiogram. This is her echocardiogram. On the right, you have a sort of a modified apical four-chamber focused on biatrial chambers with and without color Doppler. And then on the left, this is the subcostal view, just for labeling purposes because it's focused on the biatrial chambers. This is the left ventricle, right ventricle, right atrium, and this is the left atrial apparatus. As you can see, there is a membrane in the left atrium consistent. This is the membrane, as you can see right here, right here. There is a membrane in the left atrium consistent with core triatriatum sinister. It's called sinister because it's found in the left atrium. The fenestration between the posterior and anterior chambers, as you can see here in the color Doppler, is restrictive with mean gradient pressure, pressure gradient of about 12.5 millimeters of mercury, and the fenestration is deemed to be medial by the interatrial septum. Otherwise, normal left ventricular size and function, EF was about 69%, and normal right ventricular size and function. And there was at least moderate pulmonary hypertension with PA systolic pressures in the mid-50s. Oh, sorry. I will summarize her inpatient hospital course. She was admitted to the ICU for post-PA arrest care. Targeted temperature management was completed in the first 24 hours. Acute hypoxemic respiratory failure, for that she was intubated. Empiric antibiotics was started for her dense opacities. Later, she received bronchoscopy that showed diffuse pneumonia. So based on imaging and bronchoscopy findings, she continued on antibiotics. Neurology and cardiology were consulted. As part of her neuroprognostication, she was in status epilepticus by continuous EEG since early in her hospital course. She even developed generalized tonic-clonic seizure by hospital day 6, and she was on 3 anti-epileptic drugs. LP was negative, MRI and brain was grossly normal, but she continued to have no meaningful neurologic recovery. Her cardiology, she had echo, as you have seen earlier. She was on telemetry and maintained normal sinus rhythm throughout her hospital stay. ACHD was consulted peripherally via our ACHD attendings at the U. And initially, she was in shock, requiring intermittent low-dose norepinephrine early in her hospital course, but it was weaned off on hospital day 3. Her MAP calls were above 60 to 65. Otherwise, she remained to be hemodynamically stable. Recommendation from cardiology include to avoid positive inotropic given her restrictive pattern because her presentation was comparable to mitral stenosis or hypertrophic obstructive cardiomyopathy. On hospital day 8, unfortunately, she never regained consciousness. In the afternoon of that day, she had bradycardia to 30s. She had PA arrest again. Code blue was called. She has had ROSC achieved 3 times, but she kept on going back to PA arrest, and she was pronounced dead that afternoon. And autopsy was later obtained. I would let Dr. Marshall take over for the discussion of the autopsy findings.
Thank you so much, Fitz. Let me share my screen.
I will stop my screen sharing here then.
Okay, does that look okay?
It looks great.
Okay, thank you. I'm having some screen issues. So yes, so this autopsy was actually performed by Dr. Kelly Smith, who's one of our cardiac and renal pathologists, along with a resident trainee, Crane Wu. So we'll start with the heart. So the main findings were, externally, the heart was relatively normal appearing on the anterior surface. I apologize for kind of the warm intensity of the photo. It weighed 300 grams, which is, pretty normal for a female. And, one of the things that sort of sticks out is like the great vessels are a little interesting here. Potentially, the pulmonary could be slightly dilated. When we look at the back, you can't really see much on this view, but we're going to be coming in and focusing on the posterior, on the left ventricle. So actually, I'd like to show you this picture first. So this is the left atrium. And as Fitz was describing, there is a core triatrium with this fibromuscular septum here, which produces this kind of superior or, accessory chamber or posterior anatomically. And then you have what would be the more native left atrium below, which still includes the valve and the left atrial appendage, whereas the pulmonary veins are draining into this small chamber here. And you can see here, this is the opening for the communication between the two chambers, which was about half a centimeter or so. So that would, cause definitely a pressure differential. This is when it's been opened up. So you can see this is the main kind of anterior left atrial chamber. And this is that little communication that would then be emptying, which would be communicating to that superior chamber. Sorry. One of the things I wanted to mention was, this was relatively small. It was kind of like this little tubular area, kind of this channel. It was, I think not more than kind of 3 centimeters in max diameter. The other finding, which was pretty striking in this case, was even though the heart, generally appeared pretty normal otherwise, as far as, the arrangement of the chambers, valves and things like that, there was a striking amount of thickening of the right ventricle. And oftentimes with right ventricular hypertrophy, the thing that stands out initially at first is just how thick and prominent the trabeculae become. You see how large these are. And then actually the wall thickness becomes quite thicker. So usually the posterior is a bit thicker than the anterior, but here they're basically approaching the same thickness, and it measured up to 0.7 centimeters, and usually we'll accept 0.5 or less. This is a little bit misleading just because of the zoomed in nature. So her left ventricle was not thickened. It measured like a centimeter. We don't include the trabeculae when we're measuring those thicknesses. And then there was no other evidence of, any lesions in the heart itself, no areas of, scarring or anything that looked concerning for any kind of an acute infarct. And the coronary vessels were totally clean. And there were no additional abnormalities, indicative of other malformations that can sometimes come along with the triatrium, particularly that there was no atrial septal defect. So I really want to highlight the additional systemic findings. And so the first finding that was a bit unexpected and, somewhat not totally in the chain of events or related to the heart defect, perhaps, there were some acute or very, recent subsegmental, kind of going from segmental to subsegmental pulmonary thromboemboli. They did not occupy a significant proportion of the vasculature, but they were definitely there. There were a few in each of the, lungs. So that would not have, helped the situation for sure. And then this is just a nice histology photo. Any of the pathology people in the audience or anybody else, just to highlight what we look for when we submit these, because sometimes if they're not, adherent to the vessel or distending it, it can be sometimes challenging to tell for sure if it's not just a postmortem blood that's kind of casting to the vasculature. So we'll take histology to look for any evidence of organization or signs of flow, because if we see this look where you have the darker red blood cells, and it's kind of this lamellated tree bark, kind of tree ring look, interposed with these pale fibrin areas, and it's alternating. So those are those lines of Zahns, and that indicates that there was antemortem flow through that clot. So that tells us, yes, this was not a postmortem artifact. We did not see, or they did not see anything like any fibroblastic proliferation or areas of significant organization. So really this did seem to be pretty recent acute events. So did not appear that she had evidence of other episodes of prior thromboemboli that would have, added to her chronic picture, at least. The lungs were very striking. So the lungs were quite heavy. They were both around 900 grams, and that's about, twice to, 3/4 what they should be. And the main finding was that they were very, very congested, and they had some edema. But when you look at them on, higher power underneath the microscope, it wasn't diffuse, but there was a lot of patchy evidence of more recent kind of alveolar hemorrhage. Some of this could just be extravasation due to the extreme congestion, but there was actually true intraalveolar hemorrhage. And then you'd have that admixed with these clusters of brown globular refractile material. So this is all hemosiderin, indicating older episodes of hemorrhage. So this has definitely been going on for a while. And then the other thing that we note, so this is a lower power view of the lung. And this here, this is a interlobular septa, and it should be just a loose area that it should not be completely pink like this. So this tells us that that space is kind of obliterated by collagen. And when we see that, that means that there's been chronic, basically chronic passive congestion and back up into the lungs where you've developed a secondary fibrosis. So that's just another sign that we see on histology that kind of supports that. And then the other thing, in addition to the more dense clusters of hemosiderin and probably actual, episodes of either microscopic or small alveolar hemorrhage that the patient was probably having, there's just kind of general throughout the lungs, just you would see scattered hemosiderin-laden macrophages. So it's probably a spectrum also of this, again, chronic congestion. And these are often colloquially referred to as heart failure cells, which are just hemosiderin-laden macrophages that you find in the alveoli. And very importantly, the vessels were abnormal. So with that chronic pressure differential, there was evidence that there was likely increased chronic pressures and stress on the lungs, leading to the development of pulmonary hypertension. So this is an H&E picture of some of the pulmonary vessels. And so here, just looking at this, this is at least kind of like double the thickness it should be. And so we have multiple layers of smooth muscle here. So there's this hyperplasia here. Sometimes we see increased thickness of the muscular wall. Sometimes we see that the intima, which you're not seeing here, gets thicker. And also the other thing you see is all this adventitial dense fibrosis. This is a Movat stain, which does a lot of wonderful things, but here what it's doing is it's highlighting the internal elastic lamina. So it really allows you to see how much thickness that vessel has change that vessel has undergone. And so that's just really highlighting that she had developed pulmonary hypertension in the setting of her congenital defect. And then finally, this isn't super striking, but it was present. So this is the liver, and this is a special stain, Masson trichrome. And so that highlights fibrous tissue or collagen. And one of the things that stands out on this more low power view is that you have relatively there's normal architecture. So here's a portal area, here's, kind of a central vein. So those should be kind of going around, and you have your plates. But you start to notice so that vein is pretty small, but here they're very dilated and there's a lot of congestion, and there's actually a bit of increased fibrosis in some areas that are focally bridging. So she, at least microscopically, has evidence that there has been chronic passive congestion, and she's actually starting to develop some sequela of that in the tissues with some early fibrosis. So that's, consistent with congestive hepatopathy, and that, can eventually, if left alone long enough, can then develop into cardiac sclerosis, which is, or cirrhosis, as some people refer to it as. So kind of just thinking through, the sequela potentially of what was happening. So, she has this long-standing congenital portal atrium, leading to this chronic backflow into the lungs and other areas, eventually leading to pulmonary hypertension with increased stress on the heart, and where we see the hypertrophy, also seeing some changes in the liver. Not really sure. I know that Fitz will be talking a little bit more about it, but somehow all of these complex mechanisms, and with her having the syncopal events, with stress on her system when she's exercising, kind of set her up to develop an arrhythmia. So just really, kind of briefly, I wanted to go over what core triatrium is, from kind of the pathology and developmental standpoint, because I did not know about this until this patient came up. So there's two types. There's the sinister, where you have the two left atrial chambers due to the fibromuscular septum. And then you have, in that case, usually the most common is you have the septum dividing, you'll have a small communication or a large communication. The size of the communication or the little fenestration dictates the presentation usually. And so in adults, when it's asymptomatic or later identified, it's usually a large communication, so there's not much pressure differential. So it often, when it's symptomatic, would present in earlier, infancy and childhood. And so what we have is in this accessory chamber, the pulmonary veins, and then in the more native or normal chamber, you have the actual mitral valve and the left atrial appendage. And then you also have the dextrum, which can involve the right atrium, but that is much less common. So in that case, you again have a septum, a membrane with a septum, and on the accessory, you have the veins draining in the superior and inferior vena cava. And then on the inferior, chamber, which is more akin to the normal or native chamber, you have the tricuspid valve with the appendage. So I won't go into a lot of detail, but there's classification systems for this. And really, this is just talking about the sinister. It's the more common one. So people have really characterized this, trying to understand kind of how it presents and how it would be managed. Loeffler in 1949 developed one of the first, the first classification of it into 3 groups. And so in group 1, there's actually no connection between the chambers. And so there is the accessory chamber may connect to the right atrium through like an atrial septal defect, or there could be anomalous pulmonary vein drainage that kind of allows for that flow of blood. In group 2, there's one or a few small openings in the membrane, which would probably be like our patient. And then group 3 is where you have a wide communication between the accessory chamber. Lamb modified the classification, and I think I would have to defer to the cardiologist, but this is the one that some folks were talking about a little bit more. And so in this case, you have the type A, which is the most common, and this is what our patient has, where you have the typical fibromuscular membrane with a proximal chamber getting pulmonary blood, and then the distal containing the normal areas. And then there's subtypes A1 and A2, which are shown here. So ours, we did not have an atrial septal defect, and then A1 and A2 are based on the presence of an atrial septal defect and the location of it either being within the accessory chamber or in the more native left atrial chamber. In type B, you have this enlarged coronary sinus, which is receiving the pulmonary vein. So that is a type of that anomalous pulmonary vein return. And then in type C, there's no connection. And so again, that would have to be having some of these additional communications most likely. Okay, and then finally, the etiology is not really clearly understood. So the embryology of this and how it develops isn't fully characterized. There's 3 main theories of how this happens. And so the first and kind of favored theory is that it's a malincorporation. So what happens is you have the common pulmonary vein fails to normally incorporate into the left atrium. So I'm going to flip back and forth between these images. So here you have the common or primordial pulmonary vein, and eventually it basically gets invested and just becomes a part of the left atrial wall. And so that's the theory, is that it just doesn't get normally incorporated and leads to this accessory chamber. Some, I guess, problems with that, is that this would potentially not have any atrial muscle in it, which they do see, things like that, but that still is kind of the favored etiology. The other is malseptation. So they, abnormal growth potentially of the septum primum, leading to this formation of this membrane and division into 2 chambers. And then finally, there's entrapment theory, where they think that the left horn of the embryonic sinus venosus somehow in that rotation and formation entraps the common pulmonary vein. So here we have the sinus venosus view. So you've got the left horn and the right horn. And the right horn, comes up and becomes part of the right atrial wall with, attached superior and inferior vena cava, and this left basically becomes like the coronary sinus and some other things. But somehow in this rotation and development, this entraps this common pulmonary vein, and you get the formation of the triatrium. Okay, so that is all I have for this case. I don't know if anybody has any questions or. Okay, I'll keep monitoring them in the chat.
Sounds good. Thank you so much, Dr. Marshall. That was very extensive, and you basically covered some of the things that I was about to say, so I'll just pass on them. So I'm not going to go much about what was already discussed, but just to say a few things. A person by the name Borst came with the term in the 1905, and it is extremely rare congenital defect, 0.1% in clinical cardiopathies and 0.4 in autopsies. Just like our case, it's associated with other congenital diseases with ostium secundum ASD or anomalous pulmonary vein return, but none of these were found in our patient. The anatomic feature and etiology were clearly discussed, so I'm going to pass on to this, and the embryologic basis was also discussed, so I'm going to pass on to this as well. The clinical presentation, the physiologic consequences directly related to the size of the orifice between accessory and the true atrial chamber, as it was discussed earlier. If it is a small foramen, then obstruction sufficient to create pressure gradient within the atrium, mimicking mitral stenosis. So basically, the pressure gradient is what dictates when these patients present. In infant and newborns, it's usually secondary to relatively narrow opening, with a subsequent rise in proximal left atrial pressure and pulmonary congestion. In adults, it's usually asymptomatic due to large foramen with no intra-atrial pressure gradient. Appearance of symptom occurs secondary to fibrosis and calcification of accessory membrane orifice in this case. In adults, usual symptoms include exertional dyspnea, orthopnea, hemoptysis, atrial arrhythmia are listed as part of chamber enlargement, but there is no known ventricular arrhythmia that is associated with this congenital defect. Cerebral and systemic emboli events were also discussed. So whenever there is a restrictive pattern, it acts like mitral stenosis. There is always a back pressure, pulmonary vascular bed congestion, and may lead to RV work overload, as it was discussed by Dr. Marshall earlier. So for our patient, it may not be completely clear as to cause of her PA arrest. There is no known association of cord triatriatum with life-threatening arrhythmia. However, her persistent long-standing pulmonary hypertension could explain her past symptoms, including pre-syncope, syncope, dyspnea and exertion, palpitation, possibly her predisposer to PA arrest. As you can see, she has had very extensive secondary changes in her lungs, and that all the changes that she has gone through may have led to PA arrest. As an alternative, she could also have had channelopathies, other rhythm disturbances, and or coronary anomalies unrelated to her congenital heart disease. Those were the proposed mechanisms, but based on our findings, it's most likely that the secondary changes that she has undergone that may have led to her PA arrest. In summary, cord triatriatum is a rare congenital heart disease characterized by the presence of quote-unquote triatrium, often separated by a membrane. It could be restrictive or non-restrictive depending on the size of orifice between the accessory and the true atria. If restrictive, it usually presents like mitral stenosis, and it's important to consider also non-congenital causes in congenital heart disease patients in case things do not make sense. But in our case, it sounded like it was undiscovered significant restrictive cord triatriatum that may have caused her PA arrest. And with that, we come to conclusion of the first case. I guess we can go ahead with the second case and then probably address questions later. I think there are a couple of chats. We'd probably come back to the question and answer later. Let me go ahead with the question with the second case.
Actually, Fitz, if we can pause just for a second, I think
Okay.
Dr. Krieger and Dr. Dean, maybe we'll just, before we move into the next case, see if anyone wants to comment.
Okay, sounds good.
Maybe we can have Dr. Krieger turn on his audio and
Sure.
expand slightly.
Thanks, guys. That was an incredible presentation. And as I put into the chat, it's just an extraordinarily unusual way to present with choriotriatum. I mean, typically these patients will present with symptoms analogous to mitral stenosis and exertional dyspnea, potentially atrial fibrillation, assuming it's an uncomplicated, partially obstructive choriotriatum. The fact that she could, and I apologize, I missed the very beginning of the presentation, but it sounds like she made it through with her initial symptoms being syncope followed by sudden death. And it's the first case I've ever heard with this physiology. The secondary changes that we saw, pulmonary edema, pulmonary hypertension, and liver sclerosis, seem consistent with what you'd expect from long-standing left ventricular inflow obstruction, as you might see with mitral stenosis. So potentially she was borderline compensated, and then these segmental pulmonary emboli tipped her over the edge towards an arrhythmia, potentially in the context of underlying heart failure and pulmonary hypertension.
Thank you, Dr. Krieger. There were a couple of other questions on the chat box from Dr. Mel Thompson. How reversible are the upstream changes in the lung and liver? My guess is that probably not, just because this sounds like very long-standing changes. And that I think that these are probably irreversible at the time of discovery, at least at the time of presentation. The other one is regarding if she had a prior echo. She had workup as per her outside hospital records, but there was no any clear evidence that she has had this diagnosis or whether it was restrictive or not. Most probably the fact that it was restrictive and the choriotriatum was probably found during her current presentation. All right, for the sake of time, I think we can move to our second case, which is also another interesting case that we had not too long ago. Our second case is a 44-year-old male who presented to our clinic for a new heart failure evaluation. He has had dyspnea and exertion for about 2 months prior to his presentation. He was diagnosed with asthma 1 year prior to presentation, and he was on inhalers. He also has bipolar disorder on lithium. He was hospitalized one month prior to his current presentation in an outside hospital at Valley Medical Center. And there he has had peripheral eosinophilia with total white cell blood count of 21,000, of which 50% were eosinophils with absolute count of 10.5. It is to be remembered that normal values are from 0 to 0.5. He had a troponin that peaked at 52 nanogram per ml, has had mild LFTs, and he also had chest CT that showed patchy bilateral ground glass pulmonary opacities in the mid to lower lungs, concerning for infectious or inflammatory process. He has had echo done that showed new low EF of 35% with interior hypokinesis and moderately increased wall thickness. And he underwent coronary angiogram that showed normal coronary arteries. He also had bone marrow biopsy that showed marked eosinophils, but no clonal proliferation. There was no evidence of myelodysplasia, clonal neoplasm, and no mutation in genes associated with myeloid or lymphoid neoplasm in this bone marrow biopsy. He received 2 doses of IV methylprednisone. His troponin went down to 24, and his eosinophils dramatically responded to 0. And at discharge, he was discharged on GDMT. Troponin sort of came back up to 37. Eosinophil count also came up to 4.6, but not as high as it was at presentation. He was discharged with hematology follow-up and heart failure referral at UW, and this is when we get to meet him. And then he came to clinic, and on presentation, this was his presenting EKG. As you can see, this EKG shows ventricular tachycardia at the rate of about 130 beats per minute. You can see P waves at a rate of 110 beats per minute, indicating AV dissociation. Right bundle branch block pattern suggests LV, probably LV origin, and predominantly R in AVF suggests a superior origin, and predominant S in 1 and AVL suggesting a basolateral wall. Overall, this was diagnosed to be slow monomorphic VT. And for this reason, patient was admitted directly from clinic to cardiology B for further workup and management. EP was consulted. He was started on IV amiodarone. He was also started on IV methylprednisone, and a lot of additional specialties were involved in his care, including hematology, ID, rheumatology, and allergy immunology consults. This transthoracic echocardiogram was obtained. These are apical 2-chamber and apical 3-chamber views with definity contrast focusing on left ventricle. As you can see, there is severe left ventricular enlargement, indexed and diastolic volume of about 110 ml per meter square, with mild concentric hypertrophy. EF was about 33%, and there was some focal wall motion abnormalities in the distal anterior wall and distal anteroseptal wall, but there was no normally functioning segments overall. And otherwise, right ventricular size and function were normal, and there was mild mitral regurgitation, tricuspid regurgitation. The pulmonary pressures were deemed to be around in the 40s, mid 40s, along with central venous pressure. We then went ahead and obtained cardiac MRI. Here you see the vertical long axis here, short axis in the middle, and a 4-chamber views in the right. Arrows highlight diffuse left ventricular subendocardial late gadolinium enhancement, as you can see here, and particularly in the basal and mid ventricular segments without edema on T2 and T1 weighted images. Otherwise, the left ventricle was moderately large with EF of about 30%, and right ventricle was deemed to be normal. Again, the highlight of this MRI was the presence of subendocardial late gadolinium enhancement, which was diffuse. Lab results include inflammatory labs. CRP was elevated, mildly elevated to 11, ESR to 48, otherwise negative ANCA, rheumatic factor and complement, and ANA were negative. Infectious workup was grossly negative. That includes HIV, hepatitis, parvo, CMV, EBV, and all the others. Fluorescence in cytohybridization was negative for platelet-derived growth factor receptors A, B, and 1. IG was elevated to 3 times the upper normal of limit. Eosinophils at admission was 3,000. As you remember, on his last prior admission, it was 10.5. That went down to 0 and then came back up to 4.6. Troponin at hospital day 5 peaked at 0.68, and BNP was 148. It was 350 at the outside hospital. In combination with the workup at the outside hospital, patient had extensive workup but still was unable to make definitive diagnosis. Thus, we pursued native cardiac biopsy, and Dr. Marshall will take over me to discuss the pathologic findings.
Thank you. I'll share my screen in a moment.
Mm-hmm.
Okay. Can you stop sharing, Fitz? I think it's. Thank you. Okay, so yes, the biopsy came to our cardiac pathology service and was reviewed by Dr. Haodong Xu. So there were at least, I think, 4, it was a sufficient biopsy. There were at least 4 biopsy pieces that were available for evaluation, and they showed similar findings. So here we have a medium power view of the heart. And so obviously, aside from the normal cardiomyocytes, which we see a little bit of fat infiltration, which is normal for the right ventricle, we have increased cellularity here with these inflammatory cells. On this power, it may be a little bit challenging to make them out. So it's just kind of noticing that there is an increased density of these cells. And then on higher power, you can see that they are actually eosinophils. They have this really dense, very bright eosinophilic granules. Oftentimes they'll get kind of crushed, and then also there may be just some degranulation. So a lot of times you'll just see the granules in the tissue as well. One of the things is that you do see these eosinophils percolating around, but most of the cardiomyocytes around them look intact. They don't look necrotic, which can be a common feature of eosinophilic myocarditis, which would be the leading differential. And then the other thing they would want to do on the biopsy is to evaluate for the degree of fibrosis in the muscle. And so they performed a Gamori trichrome, which highlights the collagen, more of this teal color. And you can see it's not super extensive in this piece, but each of the pieces had increased interstitial fibrosis kind of haphazardly in them. So there was some degree of developing kind of fibrosis in association with this inflammation. And so the diagnosis was eosinophilic myocarditis, and you get the comment where the differential is pretty broad, which can include allergic disease, drug reaction, really rare parasitic infections, malignancies, and of course systemic disorders. So you have to correlate clinically. So very briefly, since this is all I have to show for this biopsy, I wanted to just do a quick review of the histopathologic subtypes of myocarditis. I don't want to take too long because I want Fitz to be able to discuss the interesting case. So the most common type that we deal with is the lymphocytic myocarditis. And here you can see that there's just all of these lymphocytic infiltrates throughout the muscle. This should be associated with some cardiomyocyte damage to meet the definition of myocarditis. This can be seen in lots of different things. Of course, viral is the most common, but it can be pretty nonspecific. Sometimes you can have just small, scanty incidental infiltrates, and you're not sure exactly if it's significant or not. The other thing to bring up about lymphocytic myocarditis is that the histologic picture is identical to acute cellular rejection. So of course we have to, you would know if you were evaluating for that, but the other subtype is the lymphohistiocytic myocarditis. So, comprised of both a lymphocytic component and histiocytic components. And so the first subtype, which gets a lot of hype, I think, because of the nature of it, is this giant cell myocarditis. And so the infiltrates will be lymphocytes, there will be histiocytes, but the main feature that it's named after are all these multinucleated giant cells that are throughout. This is a pretty diffuse process. So typically they note that you don't have as much of the difficulty of missing things on biopsy because it does tend to be more diffuse. And of course, this one is much more, it's aggressive. There's more cardiomyocyte damage and clinically presents as a fulminant course. The thing with these lymphohistiocytic myocarditis types is they also have a little bit of eosinophils in the background. So you have to be careful, right? Like to make sure that you're putting everything together. Whereas in our biopsy, we only had eosinophils. And then the other subtype is myocarditis with well-formed granulomas. So in this case, you have histiocytes, but they're not forming granulomas, which are these tight cores of histiocytes surrounded by lymphocytes. And the prototypic one would be sarcoid. And so what we see with this is this can be very patchy, so we definitely can miss it on biopsy. It's often associated with a significant amount of fibrosis, and it has predilection for like the left ventricular free wall as well as the interventricular septum. And then of course, sarcoid is kind of the main thing that we think about, but lots of clinical, correlation, because you also need to rule out infections, that cause granulomas as well. So AFB, TB, TB, that kind of thing, fungus. But yes, so this is pretty classic of a granuloma forming myocarditis. Again, there are scattered eosinophils admixed, but they're not the predominant type in this myocarditis. And then finally, this is more flagrant than what we had. This is an eosinophilic myocarditis, and it's just sheets and sheets of eosinophils. You can have other subtypes. It's usually lymphocytes that are admixed. And again, the more typical presentation is that the cardiomyocytes aren't actually injured, although there are some fulminant types. So there's a fulminant, like kind of a necrotizing eosinophilic myocarditis that can be associated with DRESS syndrome, the drug reaction eosinophilia syndrome. And there's also, like Churg-Strauss and things where you actually have an angiitis and things. But again, it has a pretty wide differential, as we mentioned. And then finally, kind of this borderline myocarditis where you have neutrophils. This is more when you have septic patients and essentially they're having, bacteremia and disseminated infection, and you see, cardiomyocyte dropout with these neutrophilic infiltrates. So that's what that one is. And then the important thing about us, myocarditis, and to the pathologist, and of course to the clinical presentation of these late healing myocarditis, is the degree of fibrosis that happens. And for us as pathologists, recognizing that pattern. So in contrast to what you'd expect for the replacement fibrosis of like an infarct, which could look similar with, you have the healing collagen, you have a little bit of granulation tissue, some scant inflammation, is that it's more haphazard. It's not really localized to one area. And so if you see this kind of like piecemeal stuff happening, that's more indicative. And then if you have more of these kind of mixed infiltrates that are still lingering around, that could be more indicative of a myocarditis picture. And I believe that is all I have. So I'll transition to Fitz.
Thank you. Thank you, Dr. Marshall. I will start by discussing the next subsequent slides. I will answer some of the questions that were raised. The differential diagnosis prior to the biopsy included giant cell myocarditis, even though that was rare, but only because the patient was on lithium. But the more common differentials, the more likely differentials were eosinophilic myocarditis versus eosinophilic cholangitis with granulomatosis with cholangitis, which is also called Churg-Strauss syndrome, because this patient had asthma and also had this eosinophilic peripheral eosinophilia. So those were like the differentials for this patient. And then the biopsy sort of proved that it was hypereosinophilic syndrome with eosinophilic myocarditis. For the clinical course, patient was treated with IV methylprednisone pulse, transitioned to 60 milligram prednisone QD plus GDMT for the low EF. VT for the monomorphic VT, it was decided that with the AP team to ablate it, and ablation was done, and eosinophilic count reduced to 0 after all this management. This patient basically had a thorough workup ruling out hematologic malignancy associated with eosinophilia, myeloproliferative hypereosinophilic syndrome, infectious causes, and with vasculitis such as eosinophilic granulomatosis with cholangitis, or which we call Churg-Strauss syndrome, were unlikely. Per the history, hypereosinophilia measured on multiple occasions and organ involvement, which includes the myocardium and likely the lung from the chest imaging that we had. Platelet-derived close factor receptor A negative idiopathic hypereosinophilic syndrome was the most likely diagnosis. EGPA, or eosinophilic granulomatosis cholangitis, is less likely per history and workup, as he does not fit the diagnosis criteria for it. There was, even though he had eosinophilia, asthma, and transient lung infiltrates, which support the diagnosis of EGPA, there was no mononeuropathy that was identified. There were no any paranasal sinus diseases, and there was absence of vasculitis on myocardial biopsy. Our allergy and immunology team recommended mepolizumab treatment. This is an interleukin-5 antagonist and continue to protracted steroid taper. A single chamber ICD was placed. This was also something that was discussed with EP team. And because this patient had continuous VT even in the hospital stay, a single chamber ICD was placed for prevention of secondary sudden cardiac death. This slide shows troponin on the y-axis in nanogram per ml, with time on the x-axis starting early in admission during hospital course, ending all the way after discharge. And note that the peak troponin in the hospital was 0.7. Note that it's still persistently positive, even if it's not significant after the initial treatment. This slide shows eosinophilic count in 1,000 cells per microliter. You can see that the peak activity was around 4,000, and then improvement with eventual regression after the initiation of treatment with glucocorticoids and biologic agents. I just wanted to discuss about hypereosinophilic syndrome. It's a group of diseases defined by marked eosinophilia in blood and tissue with end organ clinical manifestations. It's said that up to 50 to 60% cardiac involvement. Hypereosinophilia by itself is defined as eosinophilic count of 1.5 thousand on 2 separate checks, which has to be more than 1 month apart, and or tissue diagnosis. Eosinophilia may arise from infection, parasitic or helminthic, medications, hypersensitivity disorders, metastatic diseases, endocrinopathies, autoimmune diseases, leukemia, and primary eosinophilic disorders. A very large portion of these diseases remain to be idiopathic. As I said, the syndrome has to involve hypereosinophilia as a diagnosis, plus eosinophilic mediated organ dysfunction, as it was the case in our patient. Primary hypereosinophilic syndrome is a clonal proliferation, and in this, there is eosinophilic expansion occurs in the setting of underlying stem cell, myeloid or eosinophilic neoplasm. This is considered to be clonal. In secondary or reactive hypereosinophilic syndrome, eosinophilic expansion is derived by overproduction of eosinophilic cytokines by other cell types and is considered to be polyclonal. It's usually caused by medications and parasites. A large portion of this is idiopathic, and then there are other syndrome-associated hypereosinophilic syndromes like EPGA, which is the eosinophilic granulomatosis with cholangitis. And this distinction really matters due to the need for treating the underlying etiology. Eosinophils and pathogenesis. The proposed mechanisms include direct cytotoxic effects of granules and reactive oxygen species, recruitment of other inflammatory cells, fibrogenesis, and hypercoagulability. Interleukin-5 is the major cytokine that is responsible for growth and differentiation, recruitment and activation, and also survival of eosinophils. So any biologic agent that targets interleukin-5 is a potential treatment option. As to the pathophysiology, just to summarize, there is acute necrotic event that happens early on and followed by a thrombotic event and the thrombotic stage, and then later that would convert into fibrotic state. In 2019 and 2020 were exciting times in the treatment of hypereosinophilic syndrome. Newer and promising advances were made in biologic therapy, and specifically findings of 2 agents were published, namely mepolizumab and also bernalizumab. And these are mepolizumab is an anti-IL-5 antagonist, and bernalizumab is anti-IL-5 receptor antagonist. Mepolizumab was FDA approved for idiopathic hypereosinophilic syndrome as of September 2020 for adults and children aged 12 years and older, and this was also approved for the treatment of granulomatosis cholangitis, which was also one of the less likely differentials for our patient. The patient population primary outcomes in these 2 studies include, include primary outcome proportion of patients with more than one flare during the study. For mepolizumab and for bernalizumab, it included decreased in peripheral eosinophil count by 50% at week 12, both of which achieved their primary outcome. For hypereosinophilic syndrome treatment, the current algorithm includes, if they have any myeloid neoplasm, the treatment includes imatinib or tryptokinase inhibitors. If they have myeloid neoplasm or myeloid hypereosinophilic syndrome with known defects, then they would target those specific defects with JAK inhibitors, interferon alpha or hydroxyurea. If they have a lymphoid origin, usually the treatment includes glucocorticoids with interferon and cyclosporin. And in the patient population that our patient was in idiopathic hypereosinophilic syndrome, the treatment includes glucocorticoids and targeting interleukin-5, which is the main factor that promotes eosinophilic growth and differentiation. The current approach for treatment of idiopathic HES basically includes, first line is a high-dose glucocorticoid, preference for quick transition to steroid-sparing therapy, and the presence of our anti-IL-5 or anti-IL-5R receptors are first-line steroid-sparing therapies. Similar approach regardless of specific organ involvement. So whether it's the heart or other organs, including the lungs, we would have a similar approach. Monitoring response to therapy with patients with cardiac involvement includes close cardiology follow-up, trained peripheral eosinophil count and troponin, echo as needed depending on their recovery and whatever the initial findings were, cardiac MRI and endomyocardial biopsy, of which we have utilized basically all of this. I'll just touch upon some of the findings that I got about eosinophilic myocarditis. This is a JACC paper that was published in 2017 that showed systematic review of histologically proven cases aimed at describing clinical presentation, treatment and outcome of eosinophilic myocarditis. It included about 179 subjects, which are histologically proven cases. The median age was about 41. Females were about 50%, 22% of the patients had asthma, 40% had AST elevation on admission, and 76% had peripheral eosinophilia. This is noteworthy as peripheral eosinophilia is absent in up to 25% of patients with eosinophilic myocarditis, and this contributes to underdiagnosis of eosinophilic myocarditis without biopsy. So we probably have to have echo and other clinical features to facilitate the diagnosis in order to have high clinical suspicion. Low EF is present in about 35%. LV thrombus and pericardial effusion, which are sort of the classic teachings, are present in 14% and 34% of the patients, which I found to be a little bit lower than my expectations. And our patient did not have any of these. Sudden cardiac death was present in about 27% of the patients, and out of which 11% had VT. From the same paper, this is to show that about a significant portion of these patients were idiopathic or unidentified, and of those that are identified, a significant portion of them were due to hypersensitivity, and our patient population belongs to a relatively smaller number, which is about 15 cases. Only 15 patients out of their cases series had hypereosinophilic syndrome. With regards to prognosis, the worst prognosis was deemed to be, according to this paper again, was deemed to be from hypersensitivity eosinophilic myocarditis, followed by eosinophilic granulomatosis with polyangiitis, and idiopathic, followed by the better prognosis was patients with hypereosinophilic syndrome. The hypersensitivity eosinophilic myocarditis, is the most common identified condition in about 61 patients, which was about 53%. Age was relatively younger. Eosinophilic count was relatively lower than the average, which was about 63%. So you can see that there is a chance that we may miss if we just do peripheral counts only. The most common offenders include antibiotics, and the reaction from drugs could actually could be delayed up to 2 years, which was a surprise, which I found it to be surprising. Antibiotics, the most common offenders include antibiotics, minocycline and beta-lactam antibiotics up to 35%. CNS agents like clonazepam and carbamazepine about 21%. Vaccines about 7.7%, TB drugs, and some of the medications that are rarely used but rarely associated but were mentioned include hydrochlorothiazide, but only case reports were reported related to hydrochlorothiazide and eosinophilic myocarditis. I apologize for the low quality of image on this slide, but this is just to depict a classic imaging presentation of hypereosinophilic syndrome, eosinophilic myocarditis. Here on the left side, it shows an apical four-chamber view demonstrating endomyocardial fibrosis by the yellow arrows extending along the lateral wall of the ventricle all the way down to the posterior mitral leaflet. And then you can see that there is some injury to the mitral leaflet and there is significant mitral regurgitation just because of the mitral valve was also affected. And there is usually involvement of thrombosis and endocavity thrombi, which is about 12.3%, as you can see here on the subsequent images of the same patient, CT and also echo. Clinical features of eosinophilic myocarditis due to hypereosinophilic syndrome. Of the 15 patients that were presented in this case series, who did have, it was found that low EF was similar to our patients, which is about in the 30 range, although it was interesting that a highest category of patients with ventricular thrombus and diffusion was in this category, but our patient likely didn't have any of those. LG finding was mixed, and in fact, only 5 out of 15 had MRI data available. That is probably an important limitation in the interpretation of this data. In arrhythmia, when it comes to arrhythmia, 45% of the cardiac arrest, which was about 44 patients out of the patient population, was in patients with hypersensitivity eosinophilic myocarditis, and this is during hospitalization. It did not correlate with the degree of myocardial infiltration or presence of necrosis, and most of the diagnoses were based on RV, right ventricular biopsy, which was about positive in 83.9%. The mechanism proposed is that eosinophils pose direct myocardial toxicity, even though this is not completely proved, and the cytotoxic effects of granules and reactive oxygen species are related to be the direct reasons for it. The management strategies overall include biopsy plus or minus MRI, early MCS if patients end up having fulminant clinical picture, high-dose steroids, monitoring of eosinophils and troponin, and assess risk of ACD and ICD, and also consideration of ablation in such cases of monomorphic VT, such as our patient, and treatment of underlying etiology if we find a cause for our eosinophilia and supportive care. In summary, hypereosinophilic syndrome is a rare condition, but often associated with cardiac involvement. Treatment of underlying cause of eosinophilia is necessary. New therapies for hypereosinophilic syndrome have emerged that is really great, that targets interleukin-5 or the receptor. And our allergy and immunology specialists are our friends here. Eosinophilic myocarditis is an inflammation of the heart muscle due to eosinophilic infiltration, leading to a constellation of findings, including increased wall thickness, thrombosis, fibrosis, and subacute fulminant heart failure. And ventricular arrhythmia caused by direct myocardial, by eosinophil myocardial toxicity and active inflammation, scar, or both. And this is all I have for today. All we have for today. This is a picture of my fur baby Maya in a tulip farm in Washington this summer. I'd like to thank Dr. Song Lee, Dr. Eric Krieger, Dr. Fima, and also Dr. Marshall, which was a great presentation on our current presentation. Thank you very much. Any questions?
I know we're over time, but we may have a chance for one or two comments as people move on to the rest of their day. If anyone wants to discuss either cases or if they were involved in them clinically when the patients were under our care. Looks like April has a comment.
I just wanted to comment, Fitz, that was a great review of hypereosinophilic myocarditis. I want to comment, one, the importance of biopsy in acute myocarditis. I think in the past in this program, we did not do it a lot, and I think we're doing it more, and that's good. And then the second is that the drug-induced DRESS syndrome, my readings, is just to point out, it's male dominant, and it's fairly, I don't want to say common, but it's more common in the pediatric literature, in which it's most common ages 15 to 25 in men, which intriguingly corresponds with the same peak of incidence of myocarditis in response to the COVID vaccine. And so I was glad you noted that vaccines can cause this. So just going forward with the whole questions of myocarditis and COVID, this may be a clue.
Yeah, and then probably this study did not include a lot of pediatric population, and that's probably it's a little bit on the older side, but I do agree with that statement, and yeah.
There's also a question in the Q&A. I don't know if that's been addressed yet.
Is it about the VT ablation? Yeah. So one of the questions from Lyle is for our EP gurus, is there considered an easier VT to go after in terms of ablation targeting, or is it more difficult? I don't really have a specific answer for this question. I don't know if anybody can take this.
Yeah, let's see if we have an EP colleague online who wants to take that one, and that might be our last question.
Yeah. I know for a fact that I was the EP consult during this, when this patient presented, and it was a lot of discussion that ended up, going back and forth. But the fact that it was a monomorphic VT that he continued to have throughout his hospital course in the first 10 days or so, while all other workups were being completed, he continued to have this slow VT, and that was one of the reasons that basically led us to decide to ablate, to go for ablation. But I don't think that if it is, for example, diffuse or multifoci VT, probably it might be a different discussion, but that was my limited contribution based on my involvement then.
Yes, I think that's going to wrap us up for the day. Dr. Marshall, Dr. Medhane, that was really great. Thanks everyone for joining, and looking forward to seeing you at the next Cardiology Grand Rounds.